Hello, welcome to the Faculty Development on the Fly series, sponsored by the Teaching Academy at the Robert Larner College of Medicine at the University of Vermont.
Hi, this is Dennis Beatty. I am an internist and an assistant professor at the University of Vermont Larner College of Medicine. This session is about teaching clinical reasoning skills. Here are the learning objectives for this video. As a healthcare provider, you can come up with a differential diagnosis, but can you tell how it is done? Can you explain the steps? Do you know how to teach it? Here at the University of Vermont Larner College of Medicine, one of our goals is that each medical student will gain proficiency in using hypothetical deductive reasoning, pattern recognition from illness scripts, and/or schema group diagnostics to formulate a well-thought-out, complete hypothesis list and present a concise problem representation using semantic qualifiers. Easy, right? Well, not exactly. Let's take a step back and review some terminology. There are three basic methods to assist in making a hypothesis list, otherwise known as a differential diagnosis. The first is hypothetical deductive reasoning. This involves formulating a hypothesis list at the beginning of the patient encounter and testing these hypotheses at various stages throughout the encounter. This strategy starts with making a differential diagnosis based on four initial pieces of data: the patient's age, gender, race, and chief complaint. This is done before entering the room with the patient. Here you might ask your learner which diagnoses are possible, which diagnoses are most common, and/or which diagnoses are not to be missed. At each step in the encounter, the differential is refined, which in turn identifies which additional data are needed. These steps offer opportunities to challenge the learner with questions like, what other historical information would you ask and why? What physical exam elements would you pursue and why? Does this additional information support or refute your hypotheses? Let's see how this looks schematically. You can see how the initial hypothesis list is formulated before even laying eyes on the patient, and then data from the patient's general appearance and history of present illness are used to support or refute the initial hypotheses. Next, one would revise the hypothesis list, consider what additional history questions are needed, and what physical exam elements would be important to perform. This additional information is used to further refine the differential diagnosis list and ultimately lead to an assessment. A second method to help make an accurate differential diagnosis is pattern recognition using tools called illness scripts. Experienced clinicians subconsciously use illness scripts when assessing and diagnosing a patient, but they can be taught to early learners to help organize the classic features of newly learned diseases, and also used to compare and contrast diseases that present with the same or similar chief complaint. Illness scripts have three components: predisposing conditions, pathophysiologic insult, and clinical consequences. To demonstrate an illness script, let's begin with a clinical scenario. We are presented with an otherwise well 18-year-old male with acute onset of fever, severe localized abdominal pain, vomiting, and anorexia. Consider now what would be on your differential diagnosis. You may have come up with acute appendicitis and acute gastroenteritis as possibilities. Here are illness scripts for these conditions, placed side by side for ease of comparison. In the left-hand column, you see the three components of illness scripts: predisposing conditions, pathophysiologic insult, and clinical consequences. You can then review the components of each condition and decide which script best matches the patient's presentation. A third method to use when making a differential diagnosis is a more advanced technique called schema group diagnostics. This involves breaking down the possibilities into categories. Let's use another clinical example to demonstrate. Let's say you are presented with a chronically ill 64-year-old female with a history of diabetes, atrial fibrillation, coronary artery disease, congestive heart failure, and chronic obstructive pulmonary disease, who presents with a gradual onset of fatigue. What is your differential diagnosis here? Obviously, this differential is broad and complicated. It could be helpful to break down possibilities into categories, such as cardiac etiologies, pulmonary etiologies, etc. This would help organize thoughts with some structure and also likely lead to a more complete differential. This technique does require a higher level of clinical knowledge and experience. Let's now go back to our ultimate goal. We have learned about hypothetical deductive reasoning, illness scripts, and schema group diagnostics. Next, we want to help the learner be able to present the case using a concise problem representation using semantic qualifiers. Let's explore these terms. A problem representation is a brief summary of the clinical presentation using key elements of the chief complaint and history of present illness. This is formulated after obtaining the history and physical and is used to begin the assessment and plan. The purpose of this is to improve diagnostic accuracy and also to enhance information sharing among other healthcare providers. I used a problem representation when I presented the cases we discussed earlier. Successful problem representations use words and phrases known as semantic qualifiers. These are paired, often opposing, abstract words that relay clinical information and can aid in comparing and contrasting diagnoses. One nice thing about semantic qualifiers is that they are useful to link the problem representations to the illness scripts, thus improving diagnostic skills. Let's see what these semantic qualifiers look like. These are medical terms or doctor speak, not layman's terms. See how each pair is contrasting, acute versus chronic, localized versus diffuse. You can imagine how each term would make you think differently about a patient's complaint. Is the cough acute or chronic? Is the pain mild or severe? Is the patient previously healthy or chronically ill? The strategy is to transform parts of the history and physical exam into medical terms that concisely represent the patient's story in a way that helps to support or refute classic patterns of disease presentations, also known as illness scripts. So to review, our patient presented as an 18-year-old male with a history of 2 ear infections who presents with 3 days of fever and abdominal pain, which started in the midline and moved to the right lower quadrant, became 10 out of 10 pain, and had 2 days of decreased appetite, 1 day of vomiting. Exam revealed midline and right lower quadrant tenderness, rebound tenderness, and guarding. Here, history of 2 ear infections becomes otherwise well. 3 days of pain becomes acute onset of pain, and pain in the midline and right lower quadrant becomes localized pain, etc. Thus, our problem representation using the semantic qualifiers becomes an otherwise well 18-year-old male with acute onset of fever, severe localized abdominal pain including peritoneal signs, vomiting, and anorexia. Now let's go back to our illness scripts. See how nicely the semantic qualifier terms help to compare and contrast some of the diagnostic possibilities, looking for the classic pattern that matches best. Our early learners are being taught to compare diseases with similar presentations using these illness scripts, and these will naturally be revised and refined over time as they gain more clinical experience. Also, by formulating problem representations using semantic qualifiers, they become skilled at summarizing pertinent aspects of the patient's case, at concisely presenting the case either verbally or in writing, and at recognizing patterns of illness. I hope you enjoyed this video on teaching clinical reasoning, and I hope you can use some of these strategies in your own practice and when you are teaching others.